Hello, my name is Dennis Dempsey with MITRE, and I am the Chief Engineer and Project Lead for the Medical Evaluation Readiness Information Toolset program, also referred to as MERIT. Joining me today is Mr. Juan Tang, the Chief Development Engineer. The Medical Evaluation Readiness Information Toolset is pioneering the application of artificial intelligence in military health. And this marks a foundational step to address the military's biggest challenge, medical readiness. MERIT delivers an artificial intelligence-supported medical readiness decision support capability for the DoD to produce real-time and predictive readiness acumen in support of medical disability evaluation. By introducing predictive analytic capabilities, MERIT enables DoD medical providers to make better informed clinical decisions regarding a service member's likelihood of referral to the disability evaluation system, also referred to as the DES. MERIT started as a proof of concept in 2019. Since that time, the MERIT team has developed predictive models for the top 24 unfitting medical conditions that historically lead to separation from duty and potential long-term disabilities for our service members. MERIT does this through the application of data science and artificial intelligence to analyze a service member's electronic health record. MERIT employs authoritative electronic health record or EHR data sets provided by the Defense Health Agency. The data received span 19 years and contain records for over 3 million Army service members. Our current focus is on the Army. We are just beginning field tests with Army operational units, and we plan to begin expansion to all the services in late FY22. The most important asset in the military's arsenal is the Warfighter. The service member is a critical component to executing our military mission. However, overall unit readiness is directly impacted by medically non-deployable service members. DoD policy demands that all of our service members be deployable to maximize the lethality and readiness of the joint force. The military health system and our clinicians are an essential component to keeping our service members healthy and in the fight. If a service member becomes wounded, ill, or injured, the goal of the military health system is to provide medical treatment and interventions to return that service member to duty as quickly as possible. However, one key problem we face is the period of time service members are in the medical treatment phase before referral to the DES. During this time, commanders face challenges in training a ready, deployable force. Army data from 2021 indicates that medical readiness has significant impact that challenges the Army's warfighting abilities. In 2021, 43,000 active duty soldiers were non-deployable. This is the equivalent of 12 brigade combat teams. This also has an impact financially, with annual costs of $3 billion in salary for soldiers who cannot deploy. The importance of both a medically ready joint force and digital business transformation has been well documented in national security strategic guidance. Specific to MERIT, in December 2017, the Deputy Secretary of Defense, Mr. Patrick Shanahan, called for a new construct for the DES to reduce the number of non-deployable service members. Further foundational guidance, some of which are noted here on this slide, calls for the development of technology to improve readiness by reducing the medically non-deployable population, as well as introducing artificial intelligence to improve the speed and accuracy of decision-making through digital business transformation. MITRE is answering this call and leading this evolution of an artificial intelligence-supported medical readiness support tool. We are doing this in coordination with the Joint Artificial Intelligence Center, also referred to as the JAIC, the Undersecretary for Defense for Personnel and Readiness, Health Affairs, and the Defense Health Agency. Furthermore, MITRE made a decision early in our proof of concept phase to forge partnerships directly with our government transition partners to deliver scalable AI solutions and advance the state of predictive modeling in a shared analytic environment. In partnership with the DHA and Clinical Enterprise Intelligence and Data Solutions, or the EIDS team, we recognize two significant accomplishments. Through MERIT, we drove the delivery of the first health AI cloud environment and the first instantiation of an Amazon Elastic MapReduce, or EMR, cluster in the DoD. We also established the initial footprint of the DHA's Health Data Lake, a health service architecture that resides in the EIDS team's Military Health Systems Information Portal, also referred to as the MIP. Both are significant and foundational steps into the information as a service model for the DHA and the Defense Healthcare Management System. This is our starting point, the disability evaluation system processes. As I mentioned earlier, this is also referred to as the DES. Why? One key problem we face is the period of time service members are in the medical treatment phase before formal referral into the DES. Because referring a service member into the DES is a complex clinical decision that affects a service member's career and livelihood. DoD policy directs medical authorities to refer eligible service members to the DES when the course of further recovery is relatively predictable, or within 1 year of diagnosis of a potentially unfitting medical condition, whichever is sooner. But the entire integrated disability evaluation system process takes an average 400 days, but may take up to 600 days. However, this whole process does not start until the provider determines that a service member's disparate set of symptoms correspond to a career-ending disability. MITRE can deliver an alert, much like a check engine light on a vehicle, to support medical providers in these critical decisions by delivering targeted, timely, and data-driven information. As a result, clinical decisions are more informed and can incorporate a wide range of health information not readily accessible to clinicians to aid in decision-making. As shown in this figure, MITRE can shorten this 365-day window in the pre-DES treatment period by applying machine learning and predictive analytics to service members' electronic health records. These are provided by the DHA, and they provide early indication of health risk. In the case of referral to the DES, a decision support tool such as MITRE, which provides data-driven results for medical providers to enable timely and accurate DES referral decisions, is in line with DoD policy that directs medical authorities to refer eligible service members to the DES when the course of further recovery is relatively predictable. MITRE provides predictions for those individuals who have the responsibility for fitness for duty evaluations and/or overall unit health in a manner that supports the readiness planning and decision-making. Currently, senior leader dashboards and readiness planning tools do not typically employ real-time data. In some cases, information is several weeks old. MITRE currently employs near real-time data fed directly from DHA health systems and provides capability to scale from an individual service member record to aggregate populations with services viewpoints. That check engine light I mentioned earlier can result in timely clinical and readiness planning decisions. MITRE is designed specifically with three main user groups in mind. First is the medical providers who treat injured service members and make decisions around referral to the DES. MITRE enables earlier intervention to extend a service member's military service or speed their transition and improve their quality of life. Unit commanders who are responsible for the readiness of their unit. Predictive results of MITRE can be used to monitor unit medical readiness and deployability so that commanders can train or backfill required personnel to maintain their unit's readiness. Senior military leadership and national command authorities, like the Secretary of Defense, who are responsible for readiness at the service level. MITRE provides views of medical readiness across the services by aggregating the predicted number of medically non-deployable and the predicted number of service members referred to the DES, as well as the top conditions associated with disability. Now I'm going to demonstrate for you how that works. What I'm going to step you through here is a visualization that we developed back in 2019 to show the potential capability of a predicted capability in the medical decision process. I'm going to start with that provider view that I spoke about earlier. So receiving an alert from the MHS Genesis workflow system, a clinician would go into the service member's record, and he would initially receive some information on the specific service member to ensure we're dealing with the right individual. And then it begins to provide rationale behind that check engine light coming on. And initially it provides two rationale. One is similar patients on profile, and the other is similar patients that have been referred to the DES. By clicking on each of these, I begin to see the risk factors associated with each, the probability of referral to the DES, as well as a linkage associated with risk. And I can see that changes for each as I click on them. By clicking on any of the disabling conditions, I begin to get more detail and rationale behind the decision. So we begin to show the VASR-D codes here. We show the specific conditions leading to the prediction, and we provide a disease severity index, which we'll talk about later. By clicking on either of these, the clinician is able to drill down to the specific medical encounters, see the time since the last medical encounter, and by clicking on either of these in the future, they'll be able to get to the provider notes or any other relevant information tied to that medical encounter. The next view I'm going to show you is the commander view. And in this case, a commander is looking at the disposition of his troops deployment or her deployment over the current 3, 6, 9, and 12-month timeline continuum. MITRE provides predictions as to the expected deployability, in this case of a unit of 300 individuals across that 3, 6, 9, and 12-month continuum. This is notional data, and in this case, we're showing a case of degraded deployability over that time continuum. MITRE also provides more information on each of the service members within that unit, showing each service member's disposition over that same 3, 6, 9, and 12-month continuum with a confidence factor assigned to it as well too. In this view, the commander or clinician is able to drill down based on specific specialty code. In this case, our combat medics are 68 whiskeys, and filter by company in case they want to drill down to specific skill sets or companies for deployment. The next view I'm going to show you is the service level view. And in this view, we show a roll-up of the medical readiness across each of the services and then in an aggregate for the services as a whole. In this view, senior leaders are able to drill down by COCOM or whatever force structure that is defined. We also display individuals on temporary and permanent disability status and showing that breakdown for each of the services and showing that breakdown as well for each of the COCOMs in this case here. Another viewpoint that MITRE provides is the conditions leading to early separation. And in this case, we're showing a rank order across each of the services of those conditions leading to early separation. Both of these views can be sorted in the same time continuum as the medical provider and commander views. Current state, 3-month, 6-month, 9-month, and 12-month continuums. I'll pause there and go on to the next view. What I just showed you was a user interface that was developed in 2019 to show the predictive capability of MITRE. What I'm showing you here is a user interface that has been developed with the Army and operational units within the Army. This is the clinician view, and how this has been modified. It shows basically the same information, but the minor changes are a clinician still goes in by entering the service member's ID, still provided basic information on that service member. And here, as opposed to providing the two views, we just provide a roll-up of the overall probability of the individual being referred into the disability evaluation system within the next 6 months. They're able to use the same time continuum to see how that service member's projections look over the 90 days, 6 months, 9-month, or 12-month continuum. What this view also provides is the risk of probability and how that has changed over time in a linear fashion. You can see in this case, the service member is slightly trending upwards. It also shows in a red, yellow, green donut chart, the disability probability for each of the conditions with the same aggregated view showing the linear progression of each capability. And by clicking on each of these, I can see where that individual was for that condition at that point in time. Furthermore, by clicking on the top of each of these conditions, the clinician is able to see the encounters over a period of time, as well as the specific conditions that are affecting that probability calculation. This is the first view that we began to create with our Army operational partners, and we expect to have further expansion of this view, as well as moving into the commander views over the next year. Several data sources are needed to supply the different predictors that could be used in a machine learning model. The data sources currently used are presented here. And while no single source of data can provide the totality of features that are needed for the MITRE disability prediction model, at a minimum, the predictive model is dependent on the availability of 3 things: medical encounter, service history, and known DES or disability outcomes. MITRE operates with the same restrictions that apply to other DHA systems, and our work is performed under the governance and control of the DHA EIDS team. PII that was electronically collected, maintained, or used is stored in the DHA Military Health System Information Portal, or the MIP enclave. MITRE employs authoritative data provided by the DHI, and this data is a reflection of the same data medical providers would use in making decisions and referrals to the DES today. Currently, the frequency of data updates in the MIP is monthly overall, with DoD data generally updated every week. I'm now going to introduce you to Mr. Huang Tang, MITRE's Chief Development Engineer and the brains behind MITRE. Huang, over to you, sir.
Thank you, Dennis. Next slide, please. In the plot, as you can see, the results of MITRE are very promising across all kinds of disability conditions, ranging from musculoskeletal conditions to psychiatric and neurological conditions. The 24 disability conditions listed here cover more than 90% of the cases that have been adjudicated by the DES boards in the last 20 years. The model performance presented here are of 180-day look-ahead time. Conditions are listed according to their frequency ranking over the last 20 years. And the performance metric is the area and the curve of a receiver operating characteristic, in abbreviation AUROC. For several reasons, we have chosen the AUROC as our major performance measure. First of all, disability prediction is of the nature of anomaly detection. The data sets are extremely imbalanced. AUROC as an invariant performance measure will not be impacted by the data imbalance issue. Secondly, it indicates the predictiveness of our models. Last but not least, there is some consensus on the worthiness of a model based on its AUROC measure. As it is indicated in the plot, 0.8 is a threshold for good models and 0.9 is a threshold for excellent ones. On average, the AUROC measures of the MITRE models are around 0.95, except one or two models being very close to 0.9. The machine learning methods reported here are logistic regression and a random forest. They are as elementary as it gets in the world of AI machine learning. One may ask, how can MITRE reach such good results using these elementary machine learning algorithms? The secret lies in our design of a two-stage longitudinal analysis. Next slide, please. Our predictions are in terms of the Veteran Affairs Schedule for Rating Disabilities, VASRD in abbreviation, which are diagnoses of functional disabilities. Our inputs are time sequences of International Classification of Diseases, in short, ICD-9 or ICD-10, which registers diagnosis of medical conditions and the medical procedures being applied. Even though these two can be very closely related, there are distinctions. Time sequences of ICDs serve as a surrogate to depict the medical history evolution of all aspects. On the other hand, VASRA codes, along with their respective ratings, are the aggregated snapshots of a service member's physical, mental capacity in a given area. Based on this understanding, we designed a two-stage learning scheme. First, given a service member, we evaluate the disease severity indexes of each ICD code that has ever registered on file. This is a function of time. It gives us an understanding of this service member's medical evolution across board at any given time. At the next stage, these information are fed to other machine learning algorithms to predict the evolution of his or her functional disability levels. In using ICD codes to reconstruct a service member's medical history, there are several challenges. First of all, it is well known that due to the lack of designed coders, designated coders, and the challenges from merging in-network, out-network patient records, there can be data gaps in ICD records. In addition, these time sequences are censored. In other words, we only know part of service members' complete medical history. Last but not least, encounters are extremely irregular by its nature. To mitigate these challenges, we have developed a machine learning algorithm called asymmetric logic kernel method to capture the following information in a time sequence. First, the encounter frequency, then the closeness of an encounter with respect to the decision time. Last, the decaying impact level of an encounter in distant history. And the end result turns out to be very good, as you have seen in the previous slide. Back to you, Dennis.
Thank you, Juan. MITRE demonstrated with a high degree of accuracy that the combination of ICD codes and personal records can be used to predict the likelihood that a service member will be referred to the DES. As I mentioned earlier, current field testing is underway with operational units in the Army. Future work will expand to include the Air Force, Navy, and Marine Corps, and we will incorporate additional data sources. Future work will also explore MERIT's ability to move left of diagnosis. MITRE is actively working to expand MERIT beyond DES and into other aspects of a service member's military health journey, from recruitment through transition to VA. On behalf of MITRE and the MERIT team, I want to thank you for your interest and time. We would be happy to discuss MERIT in more detail. My contact information follows. Thank you.